After doing the different types of induced abortion, let's talk about one of the very important related topic, that is fetal demise. Another term for this is stillbirth. Okay, stillbirth or intrauterine death. Stillbirth or intrauterine death. So different terms have been mentioned for the synonym. According to the definition, in utero death of a fetus after 20 weeks of gestation till before birth is called fetal demise or stillbirth or intrauterine death. So let me write those synonyms for you. Okay, yeah, it is also known as stillbirth. Very commonly used term, stillbirth. Okay, stillbirth. Another is intrauterine death. Intrauterine death. So these are a very commonly used term for fetal demise. Okay. Now, this type of fetal death can occur antenatally, which occurs before labor, or it can occur inside the labor when the labor already started, when the labor process already started. Okay, during the time of delivery, it can happen. So antenatal demise and intrapartum demise means antenatal death of the fetus and intrapartum death. That is important point. Now, what is the significance of this? One of the important, complication of fetal demise, that's why we are talking it here, is DIC. Now, it is a similar condition to missed abortion. Missed abortion means discontinuation of pregnancy, means death of the baby has already occurred prior to 20 weeks, but nothing has come out. It is continued like that. Okay, so fetal demise is a bit similar to the missed abortion, but here the death of the baby occurs after 20 weeks. This is important point. So DIC is the most serious consequence with prolonged fetal demise, which lasts there for more than 2 weeks. Now, what is the mechanism for DIC? We have studied this already. It is because of release of tissue thromboplastin from the deteriorating fetal organ. Please mute yourself.
No.
Okay. So see there, because of one or two students, to mute all of you. After some time, I'll unmute you again. So DIC is the most serious consequence with prolonged fetal demise, which lasts there for more than 2 weeks, because the tissue thromboplastin will be released from the fetal organ, and that tissue thromboplastin is a procoagulant substance which will initiate the process of DIC. Another important significance is grief resolution. Now, grief resolution means there is a shock, there is a psychological shock to the family, the psychological shock to the mother who gave birth to the dead baby. It may be prolonged, okay, if they are not appropriately addressed. So do not only treat her medically, treat her psychologically as well, so that grief resolution will be faster. These are important points. Now, another part of this topic is, what are the risk factors for intrauterine fetal death? It is most commonly idiopathic. We do not know why it is happening, okay? But some other time we know the causes, like antiphospholipid syndrome or other connective tissue disorder, or other antigen antibody reactions. Overt maternal diabetes. Overt means frank maternal diabetes, both gestational diabetes or chronic diabetes. Maternal trauma, very important cause of fetal demise or death. Severe maternal isoimmunization. Now, this isoimmunization is the same term for RH incompatibility. RH incompatibility. Now, what happens? Okay, many times we have studied this before. In the first pregnancy, probably nothing will happen because the feto-maternal exchange has not occurred till now. But from the second pregnancy onward, the mother is ready with antibody, and when that antibody crosses the placenta and goes to the baby's blood, it will cause hemolysis there. Okay, if the massive amount of antibody go, then massive hemolysis occur, which can lead to death of the baby. Fetal aneuploidy. Okay, fetal aneuploidy. Now let me ask this question for you. What is aneuploidy? Anybody?
Aneuploidy is the presence of abnormal number of chromosome in a cell.
Very good. Excellent. Excellent answer. This is abnormal number of chromosome in a cell. Normally we have 46 number of chromosome, but in aneuploidy we may have 45 or 47. So if it is not 46, we call it aneuploidy. As easy as that. Fetal infection, torch group of infection. If they occur early and till that time, probably fetus has not been dead. Later on, the fetus may die because of this problem. So all these are important risk factors. Now, what is the presentation or clinical feature and how we diagnose it? Before 20 weeks gestation, the most common finding is uterine fundus is less than the date. So before 20 weeks, if it has happened, we call it missed abortion. Please remember this. Okay. After 20 weeks only, we call it intrauterine death. There is a difference in the terminology. And when we examine that lady, the uterine fundus appears lesser than the date. Because the baby is not growing, the baby is already dead. Dead baby will not grow. So uterine fundus is lesser than the gestational age. That is the meaning of date. After 20 weeks gestation, the most common symptom is maternal report of absence of fetal movement. If the mother is clever, okay, she'll definitely feel fetal movements every day, okay, many times a day actually after 16 to 18 weeks. In primigravida, okay, they may have this feeling of the movement of the baby for the first time, which is called quickening. You already know that, around 18 to 20 weeks. But in multigravida, it may occur around 16 to 18 weeks. Now after that, she should regularly feel the fetal movement. If the baby is already dead, there will be no fetal movements felt. And sometimes this may be the presenting complaint from the mother side. For the diagnosis, we need to do ultrasound, and ultrasound will demonstrate the lack of fetal cardiac activity. That is the confirmatory diagnosis, isn't it? There is no heart movement if the baby is already dead. Now, how to manage the case? Okay, the diagnosis is very easy, simple. Just ultrasound will give the diagnosis, but how to manage it? If DIC has already occurred, we need to confirm it first by doing some lab test. So this coagulopathy should be ruled out with appropriate lab testing like platelet count. Okay, we do this all the time. So what will happen to platelet count in DIC? What will happen?
Level will decrease, sir.
Exactly.
Coagulopathy.
Always decrease. Okay, it is always decrease because platelets are consumed for the formation of thrombus. D-dimer, okay, D-dimer, the amount of D-dimer is increased. D-dimer assay will increase. Fibrinogen level will be decreased because fibrinogen is also utilized for the clot formation. Prothrombin time is prolonged. It is prolonged than the normal. Normal prothrombin time depends according to the lab actually, but it may be somewhere between 12 to 14 seconds. So it is much more longer than that. And partial thromboplastin time is also prolonged. The average partial thromboplastin time is around 35 seconds. So it is much longer than that. And let me quickly highlight one important point here, which you have already done in the DIC topic. Prothrombin time measures extrinsic pathway and partial thromboplastin time measures intrinsic pathway. Now both are abnormal in case of DIC. If it is identified that immediate delivery is necessary with selective blood product transfusion as clinically indicated. Now DIC can kill that lady, Okay, DIC is a very serious situation. So quick delivery of the baby, quick removal of the baby is very, very important one. So we'll talk about that, how to do that. This is also done by induction of the labor. If there is no DIC present till now, okay, probably the fetal demise has occurred recently. Remember, it takes almost 2 weeks time for the DIC to occur, right? So if it is still less than 2 weeks, then delivery may best be deferred for a number of days to allow for an appropriate grief response to begin. Let me explain this point for you. It may not be that harmful for the life of that lady. So see that, because till now DIC has not occurred. The baby is already dead, we know that. But that dead baby will not do any harm till the 2 weeks period. So we allow few days time for an appropriate grief response to begin. The lady should cry there. She should show certain grief. This is a big loss for the whole family actually. So this is a natural process, and we should allow that natural process to occur. Another point, if the patient wishes conservative management, follow weekly serial DIC lab test. Now, conservative management means no surgery. Probably she wants to give birth to that dead baby vaginally. Okay, and we should respect her decision. But one important point is make sure she is not developing any signs of DIC. So serial testing has to be done so that we make sure DIC is yet not happened, and we can allow that. Now, what are the modes of delivery in intrauterine death or stillbirth? See here, one is a dilatation and evacuation. This is appropriate in pregnancy of less than 20 weeks gestation if no fetal autopsy is indicated. Now, once again, if it has already happened in less than 20 weeks, we call it missed abortion, okay? So it is altogether going towards the management of abortion. So during that time, D and E may be appropriate. After that, induction of labor is a preferred way if it occurs later than 20 weeks. And induction of labor is done with vaginal prostaglandins. Now, the same type of drugs which we discussed a little while earlier, prostaglandins, they are appropriate if the pregnancy is greater than 20 weeks or if fetal autopsy is indicated, because we want that fetus, okay, as a whole, so that autopsy can be done. Sometimes autopsy is necessary to find out what is the cause of death in that baby. Sometimes it is done, but many other time it is not done. Cesarean delivery is almost never appropriate for the dead fetus. Now, why it is not appropriate for the dead fetus, the cesarean delivery? Who can answer this? Yes, guys? Anyone? Wait, maybe I have muted you. Let me check. Anybody? Why cesarean section is almost never appropriate for the dead fetus delivery? The answer is very easy. Okay?
Sir, because
yes,
the baby is dead and we have the D and E that option in induction of labor. Upper two option we have already.
Okay, good answer, Abbas. Very good. Anybody else? Anybody? Any other answer? Okay, now listen here. Caesarean section means you are giving incision on the surface of uterus and the wall of the uterus. You are cutting the wall and entering into the uterine cavity. Okay, and that uterus will become weak after caesarean section. Once caesarean section is done, okay, the next delivery is usually done by caesarean section again. She can give birth to the normal vaginal delivery. I'm not saying that, but usually she will undergo another caesarean section. So the baby is already dead. Why do you want to give a scar on the surface of uterus. It is not preferred at all. If we have some other good options like D&E or induction of the labor, we don't need to go for cesarean delivery. Okay, that is the answer. Now, how to address the psychosocial issues? This is one of the big part of our management. That lady has lost a baby. The baby is dead inside the uterus and she is going to give birth to that baby. So this is a very serious issue to her and to the whole family. Okay, so we need to address it nicely. Acceptance of the reality of the loss may be enhanced by allowing the patient and her family to see the fetus, hold the fetus, name the fetus, and have a burial which is appropriate. Okay, so they should be given the time to enjoy a little bit with that dead baby, and that will really help their psychological condition. As a doctor, we must encourage the expression of feeling and tears, which may speed the grief resolution. We should not tell them, okay, don't cry or something like that. That is not the appropriate type of counseling. We should allow them to express their feeling, and it will speed the grief resolution. And we should always tell one thing: there is no guarantee that another baby will also be born like this. You can have a very healthy baby next time. So all these types of encouraging statements or sentences has to be told to the family. Now, one more important point here: identify the cause. If you do not identify the cause, that type of counseling cannot be given. Now, how can you say like another baby will be all right if you yourself do not know the diagnosis, right? So we should do proper workup. Now see that the workup may include cervical and placental culture for suspected infection, because infection is one of the cause of intrauterine fetal death. Autopsy can be done to find out lethal anatomical syndrome. Sometimes the baby may not be, formed properly inside. Some lethal congenital anomalies may be present inside the body. Karyotyping should be done for suspected aneuploidy. This can be very easily diagnosed by karyotyping. Aneuploidy means it is not in the number of 46. It may be one less or one more than that. Total body X-ray can be done for suspected osteochondrodysplasia, a lethal type of condition, osteochondrodysplasia, and maternal blood can be checked for suspected fetomaternal bleeding, and that is done by Kleihauer-Betke stain. Kleihauer-Betke stain. Now let me say a little bit about this. This may be a completely new term for you. Okay, so listen properly here. Now this Kleihauer-Betke stain is done in the maternal blood to find out fetal RBC. Okay, to find out fetal RBC or fetal hemoglobin, you say. So if fetal hemoglobins are present in the maternal blood, and if we put acid on that blood, fetal RBCs or hemoglobin will resist the reaction with acid. So we utilize this principle for the detection of fetal hemoglobin in maternal blood, and this is called Kleihauer-Betke test. Okay, so you can simply answer to find out fetomaternal hemorrhage or bleeding. That means presence of fetal hemoglobin or RBC in the maternal blood, we do Kleihauer-Betke stain. So these are some of the important points in intrauterine fetal death. Okay, so at the end of this topic, now you can revise this slide on your own. So see here,